In this capture, we're going to take a look at CVA, or cerebrovascular accident. And the first thing we want to talk about is the two main types of strokes. And those are ischemic and hemorrhagic. And it's really critical that you understand the difference between these two types of strokes because the initial treatment is going to be different. An ischemic stroke is caused by a blockage. Okay, something is blocking it and it cuts off the blood supply distally to the blockage. In the picture, you can see that there's plaque buildup on the side and there's a clot that has become lodged in there and it's blocking the blood flow. Now, your book and the ATI talk about the different types of ischemic strokes. So you would want to know a thrombotic stroke is essentially a stationary blockage, whereas an embolic stroke is a blockage that has come and moved from someplace else. So you kind of think about as an embolic stroke, a clot that's formed in the heart in the atria because of AFib that's come up the carotid and is now causing a blockage in the brain. That would be an embolic stroke versus a thrombotic stroke where I have plaque buildup on the side, really narrow the area, and now something got caught in there. Very different than a hemorrhagic stroke. With a hemorrhagic stroke, there's actually a rupture of the vessel. So that breakage of the vessel then allows the blood to leak out into the brain tissue. So again, with a hemorrhagic stroke, you're going to have decreased circulation beyond the hemorrhage, but the other piece that you have is with that blood out in the brain tissue, it causes increased intracranial pressure. So looking at risk factors for stroke, cardiac disease. Hypertension is the number one risk factor. If you can only control one risk factor in a patient, hypertension is where you want to focus on, okay? Atherosclerosis, or the buildup of plaque on the blood vessels. Hyperlipidemia, increased levels of cholesterol and lipids in the blood, which then contribute to atherosclerosis and narrowing of the vessels, which then increases blood pressure. See how all these things tie together? And the other two things when we think about cardiac disease are atrial fibrillation. So with AFib, your atria are not contracting nicely and pushing the blood into the ventricles. They're more fluttering or fibrillating. That causes the blood and red blood cells and platelets to kind of slosh around up there and puts them at risk for developing clots. Well, as soon as that clot gets down into the ventricle, it's going to get ejected out to the body. And if you think about the left ventricle, let's say the clot gets into the left ventricle and it's going to eject out the aorta. Every time your left ventricle beats, 25% of the blood that it pumps is going to be pushed immediately up to your brain. Okay, so AFib is a huge risk factor for stroke. Valvular disease, this would be patients that have like valvular prolapse or they have some stenosis there. That's going to put them at risk for developing clots at those sites that then may get moved up into the cerebral circulation. Metabolic conditions such as diabetes and obesity are going to increase the risk for stroke. Diabetes, we talked about that way back in the GI diabetic unit. It's just going to, because of the damage that's caused to the blood vessels and the high levels of glucose in there that make things sticky, it's easier for plaque to lay down, much higher risk for heart attack and stroke. Hypercoagulability is also a factor. So patients that have consistently elevated hematocrit, and those on oral contraceptives are at higher risk for developing clots. From a structural perspective, patients that have a cerebral aneurysm or an AV malformation, they are going to be at high risk for hemorrhagic stroke because those vessels are weakened and it's going to be easier for them to rupture. Other things that put patients at risk, if they've had a previous TIA, which is a mini stroke or a previous stroke, smoking because it causes vasoconstriction and it's going to increase blood pressure, and also stimulant drugs such as cocaine. Okay, again, vasoconstriction, it increases the heart rate, increases blood pressure, and you can have a stroke. So looking at health promotion and risk reduction, we really want to look at prevention strategies, okay? So controlling blood pressure is critical. Controlling glucose levels is critical. And we do that through medications, diet, and exercise. The other thing to really look at prevention is looking at smoking cessation. Anything we can do to help reduce the risk. There's some medications that we can give prior to stroke to try to reduce the risk. So aspirin taken once a day, either 81 milligrams or 325 milligrams. That's going to help make the platelets slippery, make it a little bit harder for them to adhere and potentially cause a clot. Depending on the risk factor, your patient may be on anticoagulant medications. Patients with chronic AFib, because of that risk for stroke that we just talked about, they're typically going to be on anticoagulation, whether it's with warfarin or some of the newer agents like Xarelto. Statin medications may also be used to help reduce the risk. And statins are aimed at reducing cholesterol and lipid levels in the blood. Again, if we can address that risk factor. The two other procedures that are there are sometimes done after a stroke, but if they identify that there's a problem prior to a stroke happening, these can potentially be preventive. And the first one is called a carotid endarterectomy, and you can see a picture of that on the side, but this is where they actually go in the neck, and they generally do one side at a time, but they'll actually go in, they'll clamp off the carotid artery on one side. They will slice into the artery, and they will physically remove plaque from the carotid artery to try to improve circulation to the brain. We always worry about a piece of plaque breaking off with this, so patients are monitored afterwards, particularly for bleeding from the site, but also for any type of neurological changes that might indicate something has broken off and cause a blockage. The other thing that they can do is an angioplasty. So they can actually go through, similar to a cardiac catheterization, where they go in either through the groin or one of the arteries in the arm, thread that up through to the carotid artery, and use angioplasty like balloon to try to open up and kind of smash the plaque against the wall, kind of open that up, and then possibly even put a stent in there to keep that open. Some of our newer stents are treated with special substances to try to keep them from reblocking with your lipids and things like that. They could also potentially do a carotid bypass. If something is completely blocked, they may elect to bypass around that, similar to the way that they do coronary artery bypass. So again, those things, the surgical things, may be done post-stroke to try to minimize the damage, but if we identify risk factors ahead of time, or maybe your patient may have been experiencing TIA symptoms, they might actually do this as a preventive thing to try to prevent a future stroke. So speaking of TIA, transient ischemic attack, but essentially this is a mini stroke. That's what it is. And it is a warning sign. It is a warning sign of an impending major stroke, okay, if things are not addressed. So patients may experience symptoms of dizziness, some slurred speech, some weakness, might last for a couple hours, but generally it's completely resolved within 24 hours. So it was there and then it's not. It's caused by a temporary impairment of blood flow, and as the blood flow improves, those symptoms will improve. Okay. Again, I cannot emphasize enough, this is a warning sign of an impending stroke. We need to be able to deal with it, identify the risk factors, start getting those treated, because we want to prevent a future major stroke. Okay, we really need to begin medical management, secondary prevention. So expected findings in a patient that has a stroke, it's really going to depend on the location and the size of the injury. But what you want to keep in mind that is that the brain is cross-wired. So it's going to be opposite injury and symptoms, okay? So if I have a bleed or a blockage on the right side of my brain it's going to affect the left side of my body, okay, and vice versa. So you may see the wellness campaigns that are out there, and they teach you the acronym FAST for a stroke. I'm going to add to that because we want to be fast. We want to be fast in treating this, identifying it, so we can have a better outcome for the patient. So if you think about be fast, the B is for balance. These patients are going to have difficulty walking. They're not going to be able to keep their balance because of the equilibrium, but also because they're going to have weakness on one side. You want to look at the E. You want to look at their eyes, their vision. They may have blurred vision. They may not be able to see out of one eye, but they're going to have some differences in their vision. The F is for facial drooping. It's going to be unilateral. You're going to see it on one side. And the easiest way to do this is to have them smile. On the side that is paralyzed or weak, they're not going to be able to smile on that side. So that's really important to have them do that. The A stands for arm, but it can also be leg numbness or weakness. Again, it's going to be unilateral. It's going to be on one side. So we talk about the terms hemiplegia, hemiparesis. You want to know the difference between those two. The ataxia is going to be difficulty walking, and that kind of ties back up to the balance. The S is for speech difficulties. They may have slurred speech. They may not be able to speak. They may not be able to formulate the words, but something's off with their speech. And the T stands for time, okay? Some of the campaigns have actually started calling stroke a brain attack because that's what it is. It is no different than a heart attack, except it's occurring in the brain, okay? And just like we say time is heart muscle, time is brain function. So time is absolutely critical. Other expected findings you may see are confusion, altered level of consciousness, and with hemorrhagic stroke, they will complain of a sudden severe headache. They may even describe it as the worst headache of their life. So I mentioned before, you're going to have the cross wiring. So when you have somebody who has a bleed or a blockage on the left side of their brain, you're going to see manifestations on the right side of the body. But you also need to think about what the left side of the brain controls. It's analytical thinking, math skills, and language. Okay, so these patients may experience aphasia. They may have difficulty speaking. They may have difficulty understanding what you are saying to them, that processing piece. Okay, the agnosia, the agraphia, they might not be able to write, to communicate. Not all the time, but in general, your left-sided brain damage causes patients to be very slow, very cautious behavior. And it's very common for them to experience depression, anger, and frustration, particularly because of that difficulty with communication. They may also experience hemianopsia, where they cannot see out of the right side of their eye vision. Now, on the right side of the brain, let's say I have a blockage or bleed on the right side of the brain, that controls visual and spatial awareness. So kind of like where your body is in space. If you closed your eyes and I had you raise your hand, you would be able to sense that your hand was raised. You have an idea of where your body is in relation to space. What you see in patients that have experienced right-sided damage, they tend to overestimate their abilities. Okay, this person can be completely paralyzed on that left side, but they truly believe that they can get up and walk. Okay, so they overestimate their abilities. They have poor impulse control and judgment. They are a major safety risk. Okay, all stroke patients are a safety risk, but these ones kind of take it to the next level because they're so impulsive and they don't recognize their limitations and they have poor short-term memory and they overestimate their abilities. So major, major safety risk. You also tend to see unilateral neglect syndrome. So this would be where a patient essentially neglects the left side of their body, the left side of their vision. And we'll talk more about this in class, but literally you'll see this in patients where they might shave half of their face because it's like the left side isn't even there. They may eat off their plate and you'll see they'll eat the stuff on the right side, but nothing's been touched on the left. or makeup. They've applied makeup to the right side of the face, but the left is nothing. So you can see that, as well as loss of depth perception, which then again contributes to that safety risk. Okay, so for emergent care for an acute CVA, at this point, I don't know if it's ischemic, I don't know if it's hemorrhagic, I'm just looking at emergent care. I need prompt diagnosis, prompt treatment. So the first thing that we're going to do is that patient's going to arrive, somebody's doing the NIHSS stroke scale. Okay, we use a special assessment tool that looks at multiple different areas very quickly to evaluate the patient and give them a score of anywhere from 0 to 42. The higher the number, the more advanced, the more involved the stroke is. Okay, but nurses get trained on the NIH stroke scale. Okay, and there's actually, you need to take the test on it, you need to be certified in it. If you know your stroke scale, you can administer it very quickly, within a matter of minutes. This patient needs a non-contrast CT scan to determine the type of stroke. That needs to be done within 25 minutes of arrival to the facility. And what will happen is, if it's EMS bringing the patient in, the hospital will know in advance because there's somebody en route, and they will initiate the stroke protocol. Okay, which means this person is going to the head of the line for that CT scan because this timing is critical. The other thing we need to look at is supporting the airway, breathing, circulation. So supporting the airway, they might need an oral airway. Depending on their level of consciousness, they may need intubated. They may need assistance with oxygenation, just nasal cannula or a mask, or they may need full-fledged ventilation. From a circulatory standpoint, they're going to need IV access. We're going to want to get IV fluids going. But the critical piece, as we're supporting those ABCs, is to determine what type of stroke this is, because the treatment that we do is going to vary. And if you treat a hemorrhagic stroke with the ischemic stroke protocol, you will kill your patient. Okay, so it is critical that we identify what type of stroke this is. So now let's focus specifically on ischemic stroke. Okay, so this is acute care for ischemic stroke. So for ischemic strokes only, we may be able to give TPA. And this is essentially a clot-busting drug that is aimed at busting up the clot and reestablishing blood flow. However, certain criteria need to be met. Okay, the first thing is that obviously it needs to be an ischemic stroke. Okay, and the other thing is we need to know the time of symptom onset. Those are the first two things that, those things are going to rule out a patient for being a TPA candidate right off the bat if we don't know what's going on there. The reason that we do that is your body, as a natural compensatory mechanism, when there is a blockage, okay, it tries to create collateral circulation. Once we get beyond 3 to 4.5 hours of symptom onset, the TPA, the effectiveness of the TPA, it's going to work, but we're not going to see a huge benefit in the outcome of preventing deficits, okay? And it's going to increase the risk for bleeding and potential hemorrhage. So that 3-hour window is kind of the standard. In some cases, it might be extended to 4.5 hours after symptom onset, not arrival time at the ER, symptom onset. Okay, so that 3 hours is something you want to keep in mind. This patient, we look at the risk versus the benefits. Okay, so ideally we're looking at reestablishing blood flow and reversing those deficits. However, there's certain things that are going to exclude them. If they are already on anticoagulant therapy, they're not a candidate for TPA. If they're actively bleeding or they've had a GI bleed within the last several months, they're not going to be a candidate. Menstruating females are generally not candidates for this. Obviously, in every situation, they're going to look at the benefit versus the risk for that individual patient. Okay, these patients are going to be in the ICU, or they should be in the ICU. We may start TPA in the ER, but we got to get them to the ICU or some sort of acute stroke unit. They're going to be on continuous cardiac monitoring, and we're going to have very frequent neurological and vital sign assessment, because as that clot dissolves, as that clot gets busted up and blood flow gets reestablished, we should see improvement in their neurological status. If we don't, or heaven forbid, we see a worsening of the status, we worry about potentially the TPA might have caused a bleed. And now not only do they have a blockage, but now they have a hemorrhage as well. So that frequent assessment is critical. Continued care, we're obviously continuing to support their ABCs. We mentioned the neurochecks, ongoing cardiac monitoring. For your patients that are not TPA candidates, we don't just close the door and say, well, you can't have TPA, best of luck to you. What we do is we try to take action to prevent the clot from getting bigger or to prevent additional clots from forming. So they typically start them on low dose aspirin within 24 to 48 hours. Some places may start them on anticoagulant therapy. Some of our newer research kind of shows that that may not be as effective as we first initially thought. So it's a little bit controversial. So that will be up to the specific facility protocol or the provider. Okay, so you may see them on anticoagulants. They're also going to be placed on seizure precautions. It is very common for patients post-stroke to experience seizures. Continued acute care, we may look at surgical procedures to remove the blockage, depending on where it is. Sometimes they can actually do that, from a vascular standpoint. They can go up similar through a cardiac cath, maybe retrieve the clot. Depending on the situation, there have been times they've done extracranial, intracranial bypasses. But if we can remove the blockage, we definitely want to do that. The big thing we need to look at is maintaining what we call cerebral perfusion pressure. So you'll hear this referred to as CPP. And basically, just, as a down and dirty definition, basically you're looking at, I need to maintain enough pressure for the brain to be perfused. Okay. The way we do this is we look at controlling blood pressure and we look at controlling intracranial pressure. Okay, so looking at overall cerebral perfusion pressure. So we want to control blood pressure. And our goal range, keep in mind, one of the biggest risk factors for stroke is going to be hypertension. So we don't want to bring them down to a completely normal blood pressure. We generally try to keep them between 140 and 180 systolic and 80 to 105 diastolic. We will continue to work trying to bring their pressure down over time as a long-term management strategy to prevent future CVAs. But right now we need to maintain that cerebral perfusion pressure. So we'll use antihypertensive meds to kind of keep them within that range. Hydralazine and labetalol can both be given IV push, which gives us a much quicker onset of action. Plus we don't have to worry about swallowing issues. We can get that in them very quickly. We might use an IV osmotic diuretic. It's called mannitol. That can help in reducing intracranial pressure. We would like to keep their head of bed elevated at least 30 degrees and their head in a neutral position, because that helps facilitate venous drainage from the head and neck. You want to avoid any extreme neck flexion or extension. Okay, switching gears now. Now we're talking hemorrhagic stroke. Okay, hemorrhage, not blockage, hemorrhage. So this is going to present, your patient's going to present very similar to an ischemic stroke. Things that might be different, again, I mentioned before, that severe headache, that worst headache I've ever had. They may have very early and sudden changes in level of consciousness, and that is simply because you have the bleeding out into the brain tissue that's going to elevate intracranial pressure. Also, as a consequence of elevated intracranial pressure, it can cause projectile vomiting. Okay, you don't typically see that with an ischemic stroke. You'll potentially see it with a hemorrhagic stroke. From a diagnosis standpoint, again, we're back to that non-contrast CT. That needs to be done within 25 minutes of arrival so we can figure out, are we dealing with an ischemic stroke and we're going to go down that pathway, or are we dealing with a hemorrhagic stroke and we're going down a separate pathway? That is critical. They may do cerebral angiography to actually find where the bleed is and potentially repair the bleed. They may or may not do a lumbar puncture if the CT is negative. They will only do that if the intracranial pressure is not elevated. We're not seeing signs of intracranial pressure elevation. That can confirm the hemorrhage. But when they do that lumbar puncture, when they do that initial puncture to get the cerebral spinal fluid, that can cause a sudden spike in ICP. So if it's already elevated, that could potentially cause brain herniation. So it's kind of up in the air whether or not they'll do an LP or not. For a hemorrhagic stroke, the reality is the care is primarily supportive. The body on its own is going to try to stop the hemorrhage. It's very similar to when you cut yourself if you're shaving. Platelets and clotting factors go to the site of the injury and form that fibrin clot to stop the bleeding. The key is going to be keeping that area from rebleeding. Okay, so most of our care is going to be supportive. We want to control blood pressure. We don't want any spikes that could possibly then rupture and rebleed that very delicate clot that's there. Sometimes we'll need to do surgery. If there's a hematoma, depending on the location, that blood that's accumulated outside of the vessel, that's hopefully then resealed off, that may need to be evacuated. If it's an aneurysm, okay, we may need to go in there through the vascular system and do a surgical repair that they can clip, they can wrap, coil them. If your patient has an AVM, okay, and your patient may not know that they have an AVM. They're typically congenital or genetic. They might develop later in life. Usually your patient doesn't know they have it unless it's found incidentally. Through a head CT, I'm looking for something else. If we know they have an AVM, that they can do preventative things to fix the AVM before a hemorrhagic stroke happens. But once it happens, it's happened. They can also do a ventriculostomy. This is a invasive way of monitoring ICP, and it also allows for the drainage of cerebral spinal fluid out of the system as a way to try to manage ICP levels. Again, as I mentioned before, continued support of the ABCs. We're essentially waiting for the body to heal itself. Frequent neuro checks. We want to monitor, is this patient getting worse? Are they staying the same? Are they getting better? Ongoing cardiac monitoring. These patients are also at risk for seizures because of the elevated intracranial pressure. So it is not uncommon for hemorrhagic stroke patients to be on medications to try to prevent seizures and for them to obviously be on seizure precautions. Padded bed rails, suction nearby, always IV access, just in case they would have one, but we're really trying to prevent it. And again, as I mentioned before, our biggest goal for these patients is to prevent rebleeding or vasospasms, where you have spasming of the vessels, which can cause intermittent blockage of blood flow, and that can also trigger a rebleed. So we want to make sure they're hydrated. We essentially want a euvolemic state. We don't want them deficient. We don't want them overloaded. It's like, Goldilocks and the Three Bears. We want it just right. And we want to keep their sodium within normal range. They may use a medication. It's called nimodipine. And they use that to stabilize blood vessels. That kind of helps prevent vasospasms. And again, we're looking at controlling the blood pressure. Our goal of 140 to 180 systolic, 80 to 105 diastolic. And we'll use IV antihypertensive meds to do this. Again, managing ICP, so we may use mannitol with these patients, still elevating the head of bed 30 degrees, still watching that head neck position. If your patient has an aneurysm, we may need to incorporate those aneurysm precautions. They're detailed in your book, but essentially kind of just think about anything that can increase your blood pressure is going to put that aneurysm at risk of rupture. These patients will be on bed rest. They will be sedated. A lot of times with a hemorrhagic stroke, we call it a sedation vacation, that they are on a propofol drip, they are intubated, they are on the vent, usually for a couple days post-hemorrhagic stroke, because it's going to help us control the blood pressure, try to prevent that rebleed, and it just, we're trying to minimize the damage. For our diabetic patients and even our non-diabetic patients, we want to look at glucose management, and our goal is to keep them consistently between 140 and 160. We don't want hypoglycemic episodes because that actually increases the mortality risk. And we also want to manage their temperature. It's not uncommon for patients with a hemorrhagic stroke, particularly if it's involves the thalamic artery, down by the thalamus and the hypothalamus, to have some issues with temperature management. So whether it's, high temperature or low temperature, we may have to help them thermoregulate. And finally, talking about recovery from a stroke, and we'll focus a lot on this in class, we move from the acute phase to the rehab phase. Again, in the acute phase, we're treating the acute blockage or the bleed. We're providing that supportive care to stabilize respiration and hemodynamics. And then we start actions to prevent potential complications and promote function of all body systems. Okay. At that point, we're trying to look at preventing complications and maintaining function. When we switch to the rehab phase, now we're really focusing on promoting client function. We want to minimize deficits and maximize patient functioning. Okay, so we look at promoting self-care, we look at the use of adaptive equipment, we look at assisting with communication, particularly if your patient has problems speaking or interpreting, and we also look at coping. So that's where we're really going to focus in class on that long-term post-stroke management.